Welcome to this webinar where we'll be discussing oral, oropharyngeal, nasal, and nasopharyngeal suctioning for pediatric patients. Please take a few minutes to review this disclaimer. The objectives of this presentation are as follows. We will review the Pediatric Assessment Triangle, review the basics of a pediatric respiratory assessment. We'll describe different types of secretions and what they might indicate, identify when suction is needed, discuss the different types of suctioning, and troubleshooting strategies for common problems related to suctioning. The Pediatric Assessment Triangle, PAT for short, is a tool that is used to form a general impression of a child within the first minute of your interaction with them. Ideally, you can perform this assessment in 60 seconds without the use of equipment, and often without even touching the child. There are 3 parts to the assessment that can help you form an impression of whether the child is well or unwell. These assessments are general appearance, work of breathing, and circulation. So let's talk about it. When assessing a child or infant's general appearance, a helpful mnemonic is tickles. This recalls the areas to assess for their general appearance. T for tone, I for interactivity, C for consolability, L for look or gaze, and S for speech or cry. When assessing the child and their muscle tone, are they limp? Are they stiff? Are they sitting up? Are they interactive with you or with the caregiver? Or do they look lethargic? Are they crying or upset? Are they consolable with the caregiver? Do they make eye contact? For older children, is their speech normal or slurred? Is a baby's cry high-pitched or very weak? All of this information can help you answer that question, does the child look ill? Now let's talk about work of breathing. When assessing their work of breathing, you can assess their breathing pattern, rate, as well as any audible sounds you may hear. Remember to always compare this to the child's baseline. Do you notice anything about the pattern of breathing, how the chest is rising, or are their breaths deep or shallow? Are there signs of increased work of breathing, such as nasal flaring, extended head position, retraction, or any accessory muscle use? Is the child breathing fast or slow? Do you hear any abnormal audible sounds, such as wheezing, gasping, grunting, or crackles? Does the child have an oximeter to display the oxygen saturation? Now let's talk about circulation. General circulation can be assessed by observing the child's skin color, temperature, and feel. Is the child's skin tone their baseline, or do they appear pale or dusky? Are there signs of mottling or cyanosis? Does the child look warm and dry, or do they appear flush, moist, or cold? All of these assessments will help you have a good assessment on your child. When completing a respiratory assessment on a child, remember once again to consider what their baseline is. Inspection is recommended to complete first. This allows you to gather information prior to getting close or touching the child, as this may cause them stress and alter your findings. You can inspect the size and shape of the chest movements, are their breaths shallow or deep, is there symmetrical movement, respiratory effort, do you observe any nasal flaring, retractions, accessory muscles? Are they in a tripod position, hunched over, or trying to breathe? You can also check their oxygen saturation with an oximeter. After completing the inspection component of the assessment, you can auscultate the chest with a stethoscope. Auscultate all lung fields and compare both sides, listening to the front, back, and right side for the right middle lobe, ensuring there is adequate air entry to all lobes. You can auscultate for quality and characteristics such as diminished air entry, crackles, wheezes, or grunting. Some pediatric considerations: Babies breathe mostly through their nose for up to 6 months of age. It is important to keep blankets, toys, etc. away from their nose and mouth. If congested, it can be more difficult for them to breathe. Babies and young children use abdominal muscles to pull diaphragm down for breathing, as their intercostal muscles are not fully developed. Therefore, we expect to see belly breathing. Consider what treatments or conditions have led to changes in respiratory findings in your patients. What are you most concerned about? Children who require suctioning usually have difficulty to clear their secretions on their own. Each child's needs will be different, but they usually will need to be suctioned multiple times per day. What's important is to monitor the color, amount, smell, and consistency of their secretions and note any changes that could be a sign of illness or change in condition. Consider suctioning when they are coughing more frequently or sounds more congested than usual. They seem to be unable to clear the secretions on their own. If they are having trouble breathing or breathing sounds are harsh, you can see the secretions in their mouth or nose, or you hear a gurgling noise with their breathing. There may be certain situations during which suctioning or a specific kind of suctioning is contraindicated. Some examples are after a patient has undergone an upper airway procedure, a trauma victim who may have a basal skull injury, a patient with active nasal bleeding, unless of course suction is needed to maintain a patient airway. Remember that suctioning is not without risks. It can also cause trauma and even respiratory decompensation, specifically if it's done too deeply or for too long. Some nursing considerations. Assess each patient to know how their clinical status will affect their suctioning needs. Based on your assessment and their care plan, you should know the patient's suctioning frequency, the route that's most appropriate for them, comfort measures that will make it less stressful experience for the patient, restraints, if so, what is the least amount restraints that can be used, does this patient need pre-oxygenation before suctioning, also if they're running a feed, pause it to avoid the risk of aspiration. All patients should be monitored for changes in their vital signs, for their tolerance of suctioning, and for any changes in the characteristics of their secretions. Finally, the effectiveness of suctioning should be evaluated by assessing their breath sounds before and after. The characteristics of secretions can give us a lot of information about the patient's clinical status. Thick secretions can be an indication of dehydration, chest physiotherapy just being performed, or even a lack of ambient humidity. Yellow, green, or foul-smelling secretions often indicate a respiratory infection. Blood in secretions can be a sign of airway trauma, a lack of humidity, or an infection. Brown tinge secretions could be due to old blood or infection, or frothy pink secretions are a concerning indication of pulmonary edema or fluid buildup in the lungs. We are going to review the different types of suctioning: oral and oropharyngeal, nasal and nasopharyngeal, and deep suctioning. Oral refers to suctioning just inside the mouth. Oropharyngeal suctioning involves passing a catheter through the mouth and back to the pharynx. Nasal suctioning is just inside the nostril, while nasopharyngeal suctioning goes through the nose and back to the pharynx. Deep suctioning refers to passing a catheter beyond the pharynx, down deeper into the trachea below the vocal cords. Oral suctioning is used when a child has a weak or absent cough and is unable to remove their own secretions. They also may drool because they cannot swallow. Some older children can do their own oral suctioning. Families might also feel comfortable doing this with a younger or a tip suction catheter. Oral pharyngeal suctioning is done with a long, thin catheter and is measured from the corner of the mouth to the base of the earlobe. Its aim is to remove the mucus beyond the mouth into the throat, but not past the glottis. Nasal suctioning is used with a tip catheter and removes mucus from nasal passages. The measurement is approximately from the nostril to the cheekbone. Nasopharyngeal suctioning passes through the nose to the back of the throat, but not beyond the glottis. It is done using a long, thin catheter, which is measured from the nostril to the earlobe. Do not perform nasal suctioning if the child had a recent nose, sinus, or throat surgery, if there's a partial upper airway obstruction, or if the child has a bleeding disorder. Deep suctioning means suctioning of the trachea below the vocal cords. This is done in order to stimulate a more effective cough to remove secretions. This can be done via the nose or artificial airway, for example, a tracheostomy tube. When deep suctioning is done through the nose, it may pass into the esophagus, leading into the stomach, instead of going inside of the trachea into the lungs. Positioning and comfort measures. Ideally, a patient is in a sitting or semi-Fowler's position, with their head slightly tilted for suctioning. A patient can also be held by their caregiver or bundled for comfort. Appropriate personal protective equipment, PPE, should be worn when suctioning. Remember that suctioning can create aerosols and/or droplets, both directly or by stimulating a cough or a sneeze. PPE should be worn based on a risk assessment or your organization's policy.
In this video, we'll be going over the safety checks of a suction machine. At least once a day, ensure the battery of your machine is adequately charged and that all equipment is checked for a clean filter, tubing, and canister. Ensure that the suction catheter is the appropriate size, as it should not be larger than half the diameter of the child's nostril. An important safety check for the child's suction machine is to check the maximum pressure of which your machine is set to. On the top of the suction machine, you'll notice a gauge which will light up to indicate the maximum pressure that is currently set. You may also adjust the pressure of the machine by turning the orange dial on the side. To make sure that the suction machine is at the correct setting, we first begin to turn on the machine and include the end of the tubing with your thumb. The gauge will light up to indicate a pressure. Do not pulse the end. Here you can see the indicated pressure is at 150 millimeters of mercury. We will now adjust the suction pressure by turning the orange dial to set the new suction pressure to the desired 100 millimeters of mercury. Once you release your thumb to unblock the end of the tubing, the pressure on the gauge will disappear. This is how you perform your suction pressure safety check for your suction machine. Let's review the measurements for oral and nasal pharyngeal suctioning. Note that there are 2 holes on the side of the suction catheter and 1 at the tip of the catheter. You will need to hold your thumb over the suction control port to apply suction. To measure the depth in which you need to suction for nasal pharyngeal suctioning, take the tip of your suction catheter and start from the corner of the nostril, then measure its length to the bottom to the adjacent earlobe. In this case, it's 8 centimeters. To measure the depth of which you need to suction for oral pharyngeal suctioning, take the tip of your suction catheter and begin at the corner of the mouth, then measure to the bottom of the adjacent earlobe. This case is 7 centimeters. This video will demonstrate oral and nasal suctioning. Gather your equipment and supplies and have them nearby. Fill a clean container with sterile water or saline. Ensure your suction machine is set to the appropriate pressure. Make sure the suction machine is at the correct settings by occluding the end of the tubing with your thumb to check pressure. Do not pulsate the end. Our goal is to reach the maximum pressure when occluded. Remember, pressure settings for neonates, 60-80 millimeters of mercury. For infants, 80 to 100 millimeters of mercury. Children's or teens, 100 to 120 millimeters of mercury. In this scenario, the pressure will be set to 100 millimeters of mercury. Make sure the tubing and filters are clean and the canister is not overfull. If your child uses an oximeter, make sure it's on and providing an accurate reading. For demonstration purposes, the oximeter will be off. Wash your hands well and wear appropriate PPE. Have oxygen available if prescribed by your child's healthcare team. Make sure the child is in a comfortable position, either lying or sitting. In this demonstration, we are using a little sucker for oral suctioning. Keep the little sucker or tip catheter clean by placing it in the casing until just before use. Attach the suction tubing to a clean catheter tip or suction. Insert the suction catheter or tip into the child's mouth. Keep your thumb off the suction control port. Apply suction by holding your thumb over the control port to remove mucus. Limit suctioning to 5 to 10 seconds. For nasal suctioning, insert the suction catheter or tip into the child's nose. Keep your thumb off the suction control port. Apply suction by holding down your thumb over the control port to remove mucus. Limit suctioning to 5 to 10 seconds. Once the catheter or tip is out, clean it by dipping it into the sterile water or saline and suction to clear the tubing. Assess the child's respiratory status and oxygen needs after each suction pass. Repeat if needed, providing at least 20 seconds or more in between suctioning. This video will demonstrate oral pharyngeal suctioning. Gather your equipment and supplies and have them nearby. Fill a clean container with sterile water or saline. Ensure your suction machine is set to the appropriate pressure. Make sure suction machine is at the correct setting by occluding the end of the tubing with your thumb to check pressure. Do not pulsate the ending. Our goal is to reach the maximum pressure when occluded. Remember, pressure settings for neonates, 60 to 80 millimeters of mercury, infants, 80 to 100 millimeters of mercury, children's or teens, 100 to 120 millimeters of mercury. In this scenario, the pressures will be set to 100 millimeters of mercury. Make sure the tubings and filters are clean and the canister is not over full. If your child uses an oximeter, make sure it's on and providing an accurate reading. For demonstration purposes, the oximeter will be off. Wash your hands well and wear appropriate PPE. Have oxygen available if prescribed by your child's healthcare team. In this demonstration, we are using an 8 French suction catheter for oral pharyngeal suctioning. Make sure the child is in a comfortable position, lying or sitting. Oral pharyngeal or OP measurement is from the corner of the mouth to the bottom of the adjacent earlobe, which in this case is 7 centimeters. Avoid touching the client's face while taking measurements to ensure your catheter is clean. Keep the suction catheter clean by placing it in the case just before use. Attach the suction tubing to a clean catheter. Insert the suction catheter into the child's mouth and to the back of the throat to the marked measurement. Keep your thumb off the suction control port. You want to stay at the side of the mouth versus going straight down to the middle of the mouth to avoid gag reflex. Apply suction by holding your thumb over the suction control port. Slowly remove the catheter to remove any mucus. Limit suctioning to 5 to 10 seconds. Once the catheter is out, clean it by dipping it into the sterile water or saline and suction to clear the tubing if needed. Assess the child's respiratory status and oxygen needs after each suction pass. Repeat if providing at least 20 seconds or more in between suctioning. This video will demonstrate nasopharyngeal suctioning. Gather your equipment and supplies and have them nearby. Fill a clean container with sterile water or saline. Ensure your suction machine is set to the appropriate pressure. Make sure the suction machine is at the correct setting by occluding the end of the tubing with your thumb to check the pressure. Do not pulsate the end. Our goal is to reach the maximum pressure when occluded. Remember, pressure settings for neonates or newborns 60 to 80 millimeters of mercury, infants 80 to 100 millimeters of mercury, children's or teens 100 to 120 millimeters of mercury. In this scenario, the pressures will be set to 100 millimeters of mercury. Make sure the tubings and filters are clean and the canister is not over full. If your child uses an oximeter, make sure it's on and providing an accurate reading. For demonstration purposes, the oximeter will be off. Wash your hands well and wear appropriate PPE. Have oxygen available if prescribed by your child's healthcare team. In this demonstration, we are using an 8 French suction catheter for nasopharyngeal suctioning. Make sure the child is in a comfortable position, either lying or sitting. Nasopharyngeal or NP measurement is from the corner of the nostril to the bottom of the adjacent earlobe, which in this case is 8 centimeters. Attach the suction tubing to a clean catheter. Keep the suction catheter clean by placing it in the casing until just before use. Do not touch the end of the catheter that will go into your child's nose. Avoid touching the client's face while taking measurements to ensure your catheter is clean. You can use water-based lubricant to help lubricate the suction catheter. Insert the suction catheter into the child's nostril in a downward position versus upwards to the marked measurement. Be careful not to force the catheter. If you meet resistance, try the other nostril. Keep your thumb off the suction control port. Apply suction by holding your thumb over the suction control port. Slowly remove the catheter to remove mucus. No twirling except for tracheal suctioning. Limit suctioning to 5 to 10 seconds. Once the catheter is out, clean it by dipping it into the sterile water or saline and suction to clear the tubing if needed. Assess the child's respiratory status and oxygen needs after each suction pass. Repeat if needed, providing at least 20 seconds or more in between suctioning.
Suctioning may cause a child to feel short of breath as it removes oxygen from their airway. If the child ever becomes blue or desaturates significantly during suctioning, remove the catheter immediately. Administer oxygen, if available, until the child recovers. It is important to know when to call for help. Now let's discuss a patient case together. You are caring for an 11-month-old patient with a viral respiratory illness and recognize the need to nasopharyngeal suction. With NP suctioning, the patient has an incredibly strong cough reaction, rolling and turning their head in bed. The cough sounds very productive and you get a large amount of secretions. However, the patient still sounds congested after one suction pass. Now let's pause the video to think about your next steps. Excellent thinking. Let's discuss our next steps. The patient likely still needs more suctioning. Consider getting help from the family or others to hold the patient's hand or bundle to ensure effective suctioning. Consider another less irritating route or reevaluate the depth if you think it's possibly gone in too far. After you suction again, the patient suddenly starts vomiting. Let's pause the video now and discuss what your next steps are. Great. We would roll the patient onto the side, oral suction, and clear the mouth. Allow the patient to recover. Always do your post-assessment and make sure the patient is at their baseline. Here are some key points. In summary, when children require suctioning, remember the following. The patient's baseline respiratory status, so that you can recognize any changes when performing respiratory assessments. It is also important to perform a respiratory assessment after suctioning to verify whether it has resolved the issue or if further intervention is required. Know why the patient requires suctioning and if this is still needed regularly throughout the day or only if needed. Make sure you have checked that all of your equipment is working and the suction pressure is set to the correct setting. Involve the patient and family in care, whether that is identifying the need for suctioning, learning how to suction, or providing comfort. And know when you need further support or medical attention. Well, that brings us to the end of our suctioning webinar. Thank you for your participation. If you have any questions, please contact Connected Care at connectedcare.inquiries@sikids.ca. The email is found at the bottom of the slide. Thank you.